country ahead of politics. We welcome our colleagues to join us in moving our country and our healthcare delivery system forward. And I would now yield to Senator Murphy.
Thank you very much, Senator Baldwin, and thank you to the state of Wisconsin for, in a lot of ways, leading the way in showing us what's possible when it comes to delivery system reform. It's pretty amazing some of the statistics that you used, Senator Baldwin, when you talk about how much waste there is in the system today. The estimates are from the Council of Economic Advisors, $700 billion, from the New England Healthcare Institute, $850 billion. To put that in context, even if the median of the two is right, somewhere in the high 700 billions, that's 100 billion more than we spend every year on the military. That's enough money to provide coverage for 150 million more Americans. That's enough to pay the salaries of every single first responder personnel in the country, including firefighters, police officers, and EMTs, for over a decade. It's an enormous amount of money that we are wasting today because we have a reimbursement system, as Senator Whitehouse said as well, that essentially rewards providers and hospitals and healthcare systems for providing volume rather than providing quality. Now, we understand that there's not a single healthcare provider in the country that doesn't get into this if not for their desire to provide quality health care. There's no malevolent motives involved here, but ultimately, when you've got to keep your doors open as a medical practice, as a hospital, as a nursing home, and you get paid more the more medicine you practice and the more treatments that you order and the more tests that you have your patients undergo, then you're going to follow the money. And it's time that we reorient our reimbursement model under Medicare and Medicaid and in partnership with our private insurers so that we're reimbursing based on the quality of medicine and the quality of the outcomes that you provide rather than just on how much stuff that you order or prescribe. Let me talk about 3 examples of how we've succeeded already when it comes to changing the model of reimbursement. First, the issue of readmission rates. So when you go into the hospital for a surgery, that hospital is going to get a set fee for the surgery and for the amount of time that you spend in the hospital afterwards. It's called a bundled payment. Now, bundled payments are a good thing because what it does is that it encourages you to essentially use your resources wisely because you're not going to get paid more if you keep the person in the hospital for 10 days than if you keep the person in the hospital for 5 days. But here's the problem when it comes to the care that people were getting after a particular surgery. Because the hospital got a set payment for that period of time, they had an incentive to push the person out of the hospital as quickly as possible. And that was an incentive not only because the payment itself didn't get bigger the more amount of time that you were in the hospital, but it also was incented that way because if the person went home too early and then they came back again to the hospital got a second bundled payment when they came back. And then if they came back a third time and a fourth time, they got another payment. And so what was happening is that there was an incentive to send people home before they were ready, because not only would that save you money on the first bundled payment, but it actually made the hospital or the health system money in the long run because the person came back second or third, fourth time. Now, I don't think there was a single hospital in the nation that was deliberately misaligning their care so that they would have people coming back to the hospital a second or third or fourth time. I'm not suggesting that people were trying to game the system in that way, but what certainly was happening is that without an incentive that pulls you the other way, get the care right the first time, that there was unfortunately insufficient care being provided. And so the health care bill says, listen, we'll pay you for maybe the first readmission, maybe for really complicated procedures we'll pay you for the second readmission, but at some point there's got to be an end to this model. At some point it's got to be up to you as the hospital or as the health care provider to get the care right the first or the second time so that we aren't on the hook for readmissions occurring times 3 or times 4. That's a pretty simple change. But it can save hundreds of millions of dollars. Second example is accountable care organizations. We set up a bunch of pioneer accountable care organizations. These are bigger systems of care where you've got primary care doctors networked with specialty care providers working under one umbrella to coordinate the care of the sickest patients. There are different numbers, but they all tell the same thing, which is that the sickest 5 or 10% of patients in the country are taking up about 50% of annual medical expenditures. And so if you do a better job of coordinating the care of that small percentage of the medical population, you're going to save a lot of money. And accountable care organizations can do that. Instead of having siloed care where a comorbid patient goes to a primary care doctor over here, then a specialist here, then a specialist there, if they're all under one roof and they're talking to each other, then you can save a lot of money just by coordination. That's the theory. And so the Healthcare Reform Act put that theory into practice. It set up a pilot program by which pioneer accountable care organizations, essentially a beginning set of accountable care organizations, would be set up under a model through which Medicare would say, if you save money, we are going to deliver back to you some of those savings. So that, in fact, there's not a disincentive to practice less medicine, because if you practice less medicine, Medicare will take some of the savings and then will share with you some of the savings. Well, we've only had a year or so of returns from this model, but the results are pretty stunning. The average increase in cost per beneficiary has been, in the pioneer ACOs, less than 50% of that for non-pioneer ACO models. That's a pretty significant savings. In addition, go back to this question of readmissions. In 25 of the 32 pioneer ACOs, there was a lower risk-adjusted readmission rate than in non-pioneer ACOs. Coordinated care, where you're reimbursing an organization as opposed to just the individual physicians, actually saves you a lot of money. And then third, the issue of outliers. What you find when you look at the data, and it may be that Senator Whitehouse talked about this, is that sometimes 60, 70, 80% of the system is practicing good medicine at the right cost. And it really is only a small handful of providers that are way outside of the median. And all you have to do when it comes to some subsets of reimbursement is bring back in those outliers into the median. Home care was a great example. In the Accountable Care Act, we said that for home care providers that had utilization rates that were far outside the median, we were going to stop reimbursing for those episodes that were far outside the median. Now, CBO wasn't sure how to score it because they didn't really know that that was going to change people's practice, but it did. And it's estimated that that single change in controlling for the handful of outliers when it comes to high utilization rates in the home care line item is going to get us almost $1 billion in savings over a 10-year period of time. And when you look at home care, actually, it's only a handful of areas in which you have these outpaced utilization rates compared to the rest of the country. It's places in Texas, it's places in certain counties in Florida. Most of the country is, right where you should be. And so part of reforming our delivery system is also taking care of these outliers. We've seen savings, whether it be in controlling readmission rates, setting up accountable care organizations, or taking on outliers within our home care system. And now it's time to do more. Because, Mr. President, before I turn it over to my good friend Senator Blumenthal, here's where the rubber hits the road. In about 10 years, Medicare starts taking in less money than it sends out. It doesn't go bankrupt all of a sudden, but it starts to become fiscally insolvent. And there's only a handful of ways to stop that reality from happening. You can either ask beneficiaries to pay more out of pocket. You can cut their benefits, give them less. You can ask people to pay more into the system while they are working, or you can make the system more efficient. Now, it may be that we have to do a mix of those, but clearly the first three are not that palatable. Reducing benefits, increasing copays, or increasing taxes. This isn't a partisan issue. Both sides agree that in 10 years we have an accounting problem in Medicare. Both sides agree that we have to make changes today in order to stop that crisis from occurring. And it strikes me that if the most conservative Republican and the most liberal Democrat sat down at a table and looked at those four options, increase copays, reduce benefits, increase taxes, or increase efficiencies, we would all agree, the conservative Democrat and the conservative Republican and the liberal Democrat would agree, along with probably every other member of this body, that the first place you should go is to reduce inefficiencies. That's what the delivery system provides. And so we've set up a working group here in the Senate, which is beginning its work this week, that Senator Baldwin, Senator Whitehouse, Senator Blumenthal, I, and others will be building over the course of the late summer and fall. We hope that it will draw interest from both sides of the aisle so that we can really start to put some meat on the bones when it comes to the changes in our delivery system that can be made to increase efficiencies so as to forestall the need to balance the Medicare books on the backs of taxpayers, workers, or beneficiaries. With that, let me yield the floor to my great friend from Connecticut, someone who both as a senator and as our state's attorney general has been fighting for health care consumers for a long time, Senator Blumenthal.
Mr. President.
Senator from Connecticut.
Thank you, Mr. President. I want to thank my colleague, Chris Murphy. Senator Murphy has been a longtime champion on this issue, and my colleagues may wonder why two senators from Connecticut, both of our United States senators, are here on the floor and part of this working group seeking to lead on this critically important issue of health care delivery reform. And the answer is that we come from a state where it is working. We've seen the future in Connecticut's health care delivery system. It's still a work in progress, a lot of work still to be done. But Connecticut hospitals and providers and insurers and patients know that it has to be our future, that cutting costs is essential to preserving and enhancing quality. Let me emphasize how important that basic principle is, because a lot of our colleagues believe there is a choice here between cutting costs and quality, that quality can't be enhanced if we cut costs. In fact, the opposite is true. Cutting the costs of health care is key to enhancing and improving quality. It's the way that we will reduce premature discharges from hospital, that we will diminish the number of discharges from hospitals without proper rehabilitation plans, and cut the number of hospital-acquired infection. It is not only possible to do, but it is essential. And it is a way that we avoid the false choice and it is a false choice, between preserving Medicare on the one hand and avoiding increasing co-pays, cutting benefits, or increasing taxes, as my colleague from Connecticut has just said. I reject every one of those options as necessary to preserve Medicare. Increasing copay, decreasing benefits, increasing taxes are not the way. In fact, it is increasing efficiencies and avoiding unnecessary, wasteful, and indeed harmful costs. Now, my mother taught me a number of things. She said, number one, if you don't have something nice to say about someone, don't say anything. So I'm not here to say not so nice things about the folks who say we ought to cut Medicare benefits. But I would oppose those kinds of cuts as unnecessary and harmful. She also said that an ounce of prevention is worth a pound of cure. And in fact, that basic truth is what will help to save our health care system. Prevention of costs, prevention of illnesses, prevention of obesity and smoking, and other kinds of diseases and conditions that lead to increased health care costs is essential to this effort. My mother said also, listen to your younger brother. My brother, Dr. David Blumenthal, has been a pioneer and an expert in this area, and as much as it pains me to acknowledge that my younger brother knows a lot more about this subject than I do, in fact, he has been to enlighten me and many of our colleagues here on this point. And I mention him and the others who are experts and pioneers in this effort, and he is one of many who have advised and provided that kind of enlightenment, because there's no more kind of guesswork as to whether advances can be made in this area by cutting costs and raising quality. It's been documented. There are projections. It can be costed out, and it can be scored, in my view, and it can be the basis for action by my colleagues here in seeking to cut costs that are skyrocketing out of control. And I've seen these reforms at work throughout the state of Connecticut. This issue is of national importance, but it hits hospitals and providers in every one of our states. I've seen it and listened to folks who work at places like St. Vincent's and Bridgeport Hospital, in Bridgeport, St. Mary's Hospital in Waterbury, Yale, New Haven, and Greenwich Hospital, Middlesex Hospital, all around the state of Connecticut. I've seen the checklists at work, the protocols for hand washing, the increased attention to quality care that also has helped reduce costs. They have helped improve patient care while reducing costs, and they reject this false choice between quality and cost cutting. Both are possible, both are essential. We hear so much rhetoric about the Affordable Care Act in Washington, but in Connecticut, we see tangible examples of how it's working and making a difference. The implementation of the Affordable Care Act is a historic opportunity for continuing this work and expanding it nationwide, and we need to continue our dedication to health care reform. My colleagues and I have come to the floor today to call for smart reforms that help patients and avoid harm to them, and do not discourage providers from being a part of the federal health care programs. In fact, we need to identify areas of reform within the health care system that we can address that will strengthen health care in this country and address these serious concerns about the skyrocketing costs of health care. Now, we've seen a slowdown in the growth of national health care expenditures over the past years, but slowed growth certainly doesn't mean a decrease in overall expenditures. Smart policy decisions require that we address the ongoing problem of health care spending in this country and turn a corner for good by reducing the current costs. I'm concerned that there are short-sighted strategies, such as taking money from the Prevention and Public Health Care Fund established under the ACA, which has been a tactic, unfortunately, used by both parties in financing programs. That tactic will undermine our long-term efforts at reducing health care spending. The Prevention and Public Health Fund is used in Connecticut for programs like mental health services and substance abuse prevention, as well as public health research and surveillance. These measures will ultimately result in lower health care spending through prevention and preventive health care. But we need to stay committed and stay the course. What we need to do now is to continue work toward developing a sustainable health care system through structural reforms such as the accountable care organizations, health maintenance organizations, patient-centered medical homes that have provided advances in this area and have created provider organizations that lead to greater provider acceptance of responsibility for health care outcomes in their patients. Measuring the success of these organizations requires taking a closer look at whether the savings and outcome improvements actually materialize. And we have to be hard-headed and clear-eyed about whether they're working. The metrics must be applied. We need to measure success, and measurements are possible. As I said at the outset, no longer a matter of guesswork. There are scientific-based measurements. The success of these organizations will have more to do with how they're run than with how they're structured. As sophisticated as many of our health systems are, the development of process goals has only recently become a consideration. The Association of American Medical Colleges recommends, for example, the use of surgical checklists through their best practices program. Peer-reviewed studies have shown that the use of comprehensive checklists is associated with reductions in complications and mortality during surgery. But they are most successful when healthcare organizations subscribe to a culture of safety. That culture of safety and prevention is essential. Some hospitals in Connecticut have been rewarded through the Medicare program for their commitment to improving quality through the use of process measures. Bridgeport Hospital, St. Mary's Hospital in Waterbury, Middlesex Hospital have all seen increases in reimbursement rates through the value-based purchasing program. Again, the federal government can provide incentives and encourage and support this effort. Manchester Memorial Hospital, Hartford Hospital, and Rockville General Hospital all have avoided Medicare penalties by lowering their readmission rates. While payment differences for these programs represent a small portion of the overall Medicare payment, hospitals should continue to be rewarded for addressing these issues. I also want to conclude by drawing attention to some of the innovative work being done in my state of Connecticut around delivery reform and data collection. I've mentioned the importance of measurements and metrics. Much of the work is supported by grants that were made available through the Affordable Care Act. But it's really been the state itself that's decided how to use these funds. While Connecticut has established a working group around innovative reforms which continue to work on specific proposals and recommendations for reforming the health care system, one of the areas of focus has been to ensure integrated clinical data exchange between health care providers. Connecticut has invested in interoperable health information technology systems and developing an all-payer claims database to create comparable, transparent information that can be better used to understand utilization patterns and enhance. One of the most basic aspects of reforming any system should be a clear understanding of where the biggest problems lie, and yet we still lack the data necessary in many systems to truly understand where the unnecessary spending is taking place. It's like diagnosis of any kind of medical condition. Facts are essential. Data are key. And I believe an investment in information technology and data collection activities will help inform payers and consumers about where our health care dollars are being sent, where they are being spent most effectively, where we can reduce spending that will ultimately enhance health care outcomes. Connecticut is taking a considered and insightful approach to obtaining and utilizing data while considering the needs of consumers and looking toward developing stronger programs for telemedicine and provider coordination. Technology is advancing. Data collection can help implement technology where it does the most good. We need tangible goals for long-term reform, and that's part of the work that we have described here and that we're undertaking as part of our task force. I know that my colleagues this evening all agree with me that we need to continue this work and take advantage of advancing technology, the metrics that exist now, the examples of good practices, the leadership of providers and the medical community, and good ideas wherever they are and whoever is willing to offer them. I want to thank my colleagues for joining in this effort. I look forward to returning on this subject. And I have now some additional remarks on a separate subject that I wish to be separated in part by a different space, if that's possible, Mr. President. Briefly, Mr. President, I want to express my strong support for the Transportation HUD Appropriations Bill that's before us and take a moment to explain an amendment that I have filed to this bill that ensures that men and women who have bravely served our country cannot be discriminated against in the housing assistance these appropriations provide. I want to thank Senator Murray and Senator Collins for their leadership, as well as other colleagues. But one of the problems that I've heard described to me by veterans relates to discrimination when they return home after serving our country abroad and they become civilian. One of the first things they often try to do is find a new home, often in a location far from their original home, where they may not be known, where they enlisted but now have left. And it may also be far from the military installation where they used to call home. Fortunately, almost all Americans across our country rightly welcome our heroes home. And they welcome them with open arms. But unfortunately, I've seen reports, I've heard descriptions of instances where landlords would not rent to veterans simply because they have served our country in uniform, and I find this practice absolutely unconscionable. Let me tell you about the case of Sergeant Joel Morgan, a combat veteran who bravely served our country in Iraq. Sergeant Morgan, upon leaving the military, wanted to rent an apartment in Boston, and he found one that he liked. Unfortunately, after hearing about Sergeant Morgan's service to our country, the landlord said that she just wouldn't feel comfortable renting the apartment to Sergeant Morgan because she opposed the war in which he fought. According to Sergeant Morgan, the landlord said, and I'm quoting, "I would suggest you do the right thing and look for a place less politically active or controversial." The place where he wanted to live was Boston. This kind of treatment is simply unacceptable to our veterans who have sacrificed so much. It is a matter of common knowledge, Mr. President, that veterans of these recent wars have high unemployment rates, higher than we should accept, higher than is conscionable for this country to accept. Among younger veterans, that unemployment rate is intolerably high. And many landlords may feel that an unemployed veteran simply isn't a good prospect for paying the rent. My amendment would prohibit any funding in this bill from going to people or organizations that discriminate against veterans in housing. It would allow anyone who sees a discriminatory practice to report it to the Department of Housing and Urban Development and directly to that agency's Inspector General. It also allows HUD to continue its existing programs to support veterans and service members. This amendment will ensure that those who fight for our freedoms will not have to find or fight for a place to call home. Discrimination against anyone, including men and women who have valiantly served, has no place in our nation. I look forward to working with the Department of Housing and Urban Development, which has done so much to protect Americans from discriminatory housing practices, on ways we can ensure that service members and veterans are not the victims of discrimination. As we work for a permanent solution on so many of these difficult problems, providing veterans with the counseling and health care and jobs and counseling and training and education that they need, and keeping faith with them so we leave no veteran behind. We should make sure that we leave no veteran out of housing because of discrimination. One of the solutions will be amending the Servicemen's Civil Relief Act to ensure that housing protections are extended to all who have served in uniform. I believe that this amendment is an important step forward. Simply put, it will protect all who have protected our country. Protecting them is a matter of keeping faith and making sure that we leave no veteran behind. I know that the Veterans Affairs Committee is hard at work on many of these issues. I am proud to serve on that committee and thank Chairman Sanders for his profoundly important leadership on this issue, along with Ranking Member Burr, and I look forward to extending and expanding these protections for our bravest and finest men and women who have helped to protect our nation. I thank you, Mr. President, and I yield the floor, and I suggest the absence of a quorum.
The clerk will call the roll.
Mr. Alexander.
Mr. President,
The senator from Connecticut.
I ask that the quorum call be vitiated.
Without objection.
Thank you, Mr. President. Mr. President, I ask unanimous consent that the Senate proceed to the immediate consideration of H.R. 2611, which is at the desk.
The clerk will report.
H.R. 2611, an act to designate the headquarters building of the Coast Guard on the campus located at 2701 Martin Luther King Jr. Avenue, Southeast in the District of Columbia, as the Douglas A. Monroe Coast Guard Headquarters Building and for other purposes.
Mr. President, I ask...
Is there objection to proceeding to the measure? Without objection.
Thank you. I further ask that the bill be read 3 times and passed, and that the motion to reconsider be considered made and laid upon the table with no intervening action or debate.
Without objection.
I ask unanimous consent, Mr. President, that the Banking, Housing, and Urban Affairs Committee be discharged from further consideration of H.R. 2167 and that the Senate proceed to its consideration.
The clerk will report.
H.R. 2167, an act to authorize the Secretary of Housing and Urban Development to establish additional requirements to improve the fiscal safety and soundness of the home equity conversion mortgage insurance program.
Is there objection to proceeding to the measure? Without objection, the committee is discharged, and the Senate will proceed to the measure.
I ask unanimous consent, Mr. President, that the bill be read a third time, passed, and that the motion to reconsider be laid upon the table with no intervening action or debate.
Without objection.
I ask unanimous consent that the Senate proceed to the consideration of House Congressional Resolution 44, which was received from the House and is at the desk.
The clerk will report.
House Concurrent Resolution 44, authorizing the use of the Capitol grounds for the District of Columbia Special Olympics Law Enforcement Torch Run.
Is there objection to proceeding to the measure? Without objection.
I ask unanimous consent that the concurrent resolution be agreed to and the motion to reconsider be laid upon the table.
Without objection.
Mr. President, I ask unanimous consent that the Senate proceed to the immediate consideration en bloc of the following resolutions which were submitted earlier today. Senate Resolution 202, Senate Resolution 204, Senate Resolution 205, and Senate Resolution 206.
Without objection, the Senate will proceed to their en bloc consideration.
I ask unanimous consent that the resolutions be agreed to, the preambles be agreed to, and the motions to reconsider be laid upon the table en bloc with no intervening action or debate.
Without objection.
Mr. President, I understand that Senate 1392, introduced earlier today by Senators Shaheen and Portman, is at the desk, and I ask for its first reading.
The clerk will read the title of the bill for the first time.
S. 1392, a bill to promote energy savings in residential buildings and industry and for other purposes.
I now ask for its second reading, and I object to my own request.
Objection having been heard, the bill will receive its second reading on the next legislative day.
Finally, Mr. President, I ask unanimous consent that when the Senate completes its business today, it adjourn until 9:30 a.m. on Wednesday, July 31, 2013, and that following the prayer and pledge, the morning hour be deemed expired, the journal of proceedings be approved to date, and the time for the two leaders be reserved for their use later in the day, and that following any leader remarks, the Senate resume consideration of S. 1243, the Transportation, Housing, Urban Development Appropriations Bill, under the previous order. Further, that upon disposition of the Paul Amendment, the Senate proceed to executive session to consider calendar number 201, the nomination of Brian Todd Jones to be the director of the ATF, and that the Senate proceed to the cloture vote on the Jones nomination.
Without objection.
There will be two roll call votes at approximately 10:45 a.m. tomorrow. If there's no further business to come before the Senate, I ask that it adjourn under the previous order.
The Senate stands adjourned until 9:30 a.m. tomorrow.
The Senate today confirmed 5 of the President's nominees to the National Labor Relations Board. The Chamber has also been considering a $54 billion spending bill covering transportation and housing programs. Work continues on that bill tomorrow, including debate on an amendment sponsored by Senator Rand Paul that would eliminate aid to Egypt. Live coverage on C-SPAN 2 when the Senate returns.
One, I think they serve as a window on the past.